World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global healthcare. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high-stakes, critical, and emergency situations. WICCEM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary, cardiovascular, and neurology specialties. From advanced training in emerging techniques to hands-on experiences in critical care, life support, and emergency medicine, our programs are designed to equip you with the skills needed to thrive in demanding environments. Our expert faculty, who offer lectures, mentorship, and innovative insights through annual conferences and webinars. With our online learning platform, you can access courses, workshops, and a rich library of resources from anywhere in the world, making education accessible no matter your location. WICCEM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare.
Good evening, everybody. So my name is Mona Juma. I'm one of the panelists for our session today. We're so happy to be among all of you tonight. And tonight we have two special speakers with us today to discuss about the importance of behavioral intervention in the world of obesity management. For all the attendees with us tonight, just, a quick catch up. So Dr. Khalid, he's the director of the Weight Management Fellowship. So what's the importance of this weight management fellowship? Currently in this world, we're all, managing and, going through a lot of cases, for weight management. And it's really, truly important for all the practitioners and, the clinicians to understand the pathology of obesity, to understand the interventions, and for us, to make sure that we're not harming the patient. And that's why, a specific course dedicated for obesity is really important. Make sure that, if you would like to register in this fellowship, so we have a specific link where you can also benefit from a discount of 10%. So make sure that you go through this link and you do your registration. And believe me that you're going to all be benefiting from this exceptional platform. So initially now, let me start with a special speaker with us today. So we have Dr. Wafa Ayish. So I'm currently working in the UAE, and Dr. Wafa, she was one of our, advocates and mentors in the world of dietetics and nutrition. And definitely she's behind many of the dietitians, not even in the UAE, but also in the Middle East. So currently, Dr. Wafa, she is the head of dietary department in Tadawi Medical Center. And also she is the president of the Society of the Middle East Parenteral and Enteral Nutrition. And she was previously the head of departments in the dietetic departments in the DHA. So please, all of us, welcome Dr. Wafa. And Dr. Wafa, the platform is yours.
Thank you, Mona. Wallah, the introduction was so warming. Thank you so much, Mona.
This is a genuine one.
Wallah, Habibti. Thank you. Thank you so much, honestly. Thank you very much. And I'm very happy to see quite number attending today. And actually, this program or this fellowship, let's say it's a guidance for everybody to know how to deal with obesity in the proper way. A lot of people deal with it differently. So at least we have to unify the protocols and the approach. And this fellowship is your opportunity to get into the track of how to unify in all over the world the way of treatment of obesity. And today I'm going to show you how the importance of multidisciplinary nutrition and behavioral integration in obesity with the 2026 consensus. Okay, please. Why multidisciplinary care is essential in obesity? Now, we know it's a lifestyle, access, socioeconomic factors, environmental, behavioral, social, so many psychological factors, biological factors, healthcare factors, disease-oriented. So many things that no one alone can deal with it. And there's a lot of myth going on. One of them, that obesity is not a disease. It's just a minor change in weight. Well, now it is clearly stated that obesity is really a disease. And not only a single thing causes it, actually it's multifactorial, where you have like dysregulation between the appetite signaling brain and gut axis, the adipose tissue dysfunction, learning eating behaviors, psychological drivers, the stress, the trauma, awards, the rewarding, the environmental exposure, the social determination of health, all of that confirm that obesity is really a disease. Not a single professional can work with that or manage all those dimensions alone. Now, the evidence base of 2023 and 2025 was the multidisciplinary obesity program. And behind the scenes, before we came out, we were talking about the importance of those multidisciplinary teams together to show and to deal with this obesity in a proper way. And all the programs were evidence-based in all over the world showed that those programs with the multidisciplinary team, greater weight loss was there, lower attritions rate, and better metabolic outcomes, and improve of quality of life, as well as reduce the weight stigma. So the obesity outcome improve everything when biology, behavior, and environmental are treated all as one pack, all together. So when we talk about who in those multidisciplinary teams, the first one is the physician, of course, or the obesity specialist. And his role is to diagnose the obesity as a chronic disease and show the stage of severity, combining the BMI with the EOSS, which is the Dimension Obesity Staging System, and prescribe pharmacotherapy or refer to surgery or only lifestyle and diet, managing comorbidities. All of that is by this physician or obesity specialist. Comes from that, he will refer them to us, where we have the role of what? Transfer or translate these medical goals into practical nutrition plans, preserve the lean mass, prevent micronutrients deficiencies, and as well support long-term adherence. So, stage severity, BMI, and EOSS, which is mentioned obesity staging system, tells you what? Tells you how much excess weight and how much it's harming your patient. So you use it, you will know where is your patient lying on the map of obesity. Coming after that, who do you think? He is the behavioral therapist or the psychologist. And I was just saying also to our next guest speaker that I need 100 of Professor Jeremy with us, because his role of addressing the emotional eating, binge eating, food addiction, identify if there's a trauma, depression, anxiety, all of that, he can discover them using CBT, ACT, motivational interviewing, or others which you will be knowing it with our next guest speaker. Then comes for that, we will not forget the physiotherapist, as you see in the picture, or the exercise specialist who will tell you what exactly the designed resistance and aerobic programs that you really need to improve your function, strength, confidence, and prevent sarcopenia as well, which is nowadays very common, sarcopenia, obesity, especially with the people who use GLP and GIP. Now there's come some studies that shows that they pop in that they might have sarcopenia, obesity due to improper weight management. We will not forget very important person who is the nurse or a health coach. Her role or their role is to follow up and continuity if they are following their medication adherence and the goal reinforcement, and definitely make sure that the patient's education was well received from all the previous team in this multidisciplinary team. So the consensus of 2026, obesity care equals to chronic disease care and long-term support. So there is a new paradigm in obesity care. And this one tells us here what is the weight management in 2026, defining that it's a chronic disease, adipose-based chronic disease, well-structured plan for lifestyle intervention, taking care of all nutrition, exercise, sleep, stress management, everything, and navigate into weight loss plateau with patience and adaptations. So it takes time, and that's what whenever they come to the clinic, the first question they ask us, how much I will lose in 1 month. Nobody knows. It's how you comply and how your body responds. Also, it's beyond the scale. Focus in the metabolic health and quality of life. 5 to 10% of weight reduction equals a significant benefits of your health, and that's what we have to tell them. By the way, obesity and the care of obesity, it's a long-term journey that we all need to take this patient with this journey on that plane. So obesity, agreed, it's a chronic disease driven by a complex of biological mechanism involving hormones, nervous system, metabolism, genetics, and other factors. And the health consequences of obesity arises from excess of dysfunctional adipose tissue, which is why obesity is now described in a better way as adiposity-based chronic disease. So, in the modern guidance frames obesity as a chronic relapsing disease that require a long-term, person-centered complications. We focus not on BMI, as I said, but combining their behavioral lifestyle therapy and pharmacotherapy and or metabolic procedures when indicated for those patients. So, in the medical or in the medicine for treatment of obesity and behavioral model that actually works as a core pillar, where most current framework converge on 3 pillars. It depends on 3 pillars. 1, the medical nutrition therapy, therapeutic nutrition, behavioral treatment, where we have the skills, the relapse prevention, the physical activities, where we have the function first, then resistance and aerobic, sleep, stress, mental health, and anti-obesity meds, as well as endoscopic or metabolic surgery were indicated. And according to the ADA 2026 obesity or weight management standards, there's a framework have been done. Also, it have been done by the Canadian guidelines, where behavioral as engine behind the sustain of nutrition and activity adherence. So this behavior is the main pillar for all of the followers who wants to reduce weight and maintain the weight reduction. Behavioral integration, what it means in practice, not in theory. Behavioral care, and I think Professor Jamie or Dr. Jeremiah will talk about it in depth, but in a fast way, it's not separated but then psychic session. It goes into medical nutrition therapy, by motivational interviewing, self-monitoring, goal setting, cognitive behavior skills, and social support and environmental redesign, where evidence support the CBT as well, cognitive behavioral skills, informed and approach to improve the adherence. And that will be in depth covered in the second talk. Now, the medical nutrition therapy minimum effect dose is how much contact and how long the dietitian to deliver this medical nutrition therapy, as well as the behavioral intervention, which are recommended for literally minimum 1 year or even longer to optimize and sustain the outcomes. Not revisit and khalas done, you can go home. No, it doesn't work like that. Even if they reduce a little bit over 3 months, continuity should be there. So the practical clinical rhythm, which is a high yield of what to do in the medical nutrition therapy, the first 0 to 12 weeks, 3 months, every 1 to 2 weeks, we go for skill building, early momentum. Coming from the 4 to 12 weeks, every 3 to 4 weeks, maintenance and preventing of relapse. And here, the relapse were mostly you lose them. So I want to prevent that so they have the continuity. After 12 months, if I succeeded, 6 to 8 weeks, we go for the chronic care model and the visit goes back, and I will give a model at the end of my talk in a bit. So the nutrition target that align with 2026 obesity pharmacotherapy reality with GLPs and GIPs therapy and stronger anti-obesity management medications, the risk shift towards what? Which I saw in my clinic. Lean mass loss, low protein intake, micronutrients gap, dehydration and constipation, weight regain when they stop. And we were talking again behind the scene before we start this about a case with Dr. Mireille, and she will maybe in the discussion talk about it, that as soon as she stopped because she didn't go for behavior and modifications of diet, she regained weight. And so many people do if they don't have the right, let's say, multidisciplinary team that take them to the right shore and make sure that they are safe and they will not gain again. It's a long-term thing. So WHO and ADA 2026 emphasize on the anti-obesity medication must be integrated into comprehensive care. Diet, activity, professional follow-up, not set as a standalone. I'll go to the pharmacy, please give me Manjaro 2.5. And not only that, I increase it by myself without going back to the real professional where you will lose yourself at that time. Clinical default, safe, practical, energy defect, individualized. We focus on adherence, not extreme restrictions like what happened. Choose at least restrictive plan that the patients can sustain and follow. Don't go for a very strict diet that they will feel fed up and get them depressed. Protein, this is a priority. And the distribution across the day, start with protein, end with protein, especially if you are taking GLP and GIP. Fluids and fibers to prevent constipation. And especially again in GLP patients, a lot of them, they get constipation because they don't feel the appetite of having fluids or enough fibers or enough fluids. They say, if I drink, I feel full, I don't eat. If I take salad, I feel full, I don't eat. So they ignore having fluids, they ignore having fibers, end up with constipation and dehydration. And the meal instructions, as I said, protein first, planned snacks if needed, and default meals for a busy day. Complications and centric decision pathway, how to choose intensity. We use the stages approach, consist according to the AACE 2025 and the ABCD algorithm and the ADA 2026. We assess complication, the drivers for TDT or type 2 diabetes or pre-diabetes, hypertension and other, GERD, emotional eating, depression, whatever. We match with intensity to severity and the readiness. Lifestyle, behavioral program, foundation for all. And then we add the anti-obesity medication when indicated or when lifestyle alone is insufficient for those patients. Consider procedural therapy when needed for severity complication. According to the EACOS pharmacotherapy framework, also stresses of matching medication, as you see in here, medication choice to complications and embedding therapy within holistic care, nutrition. See, every slide you will find nutrition, activity, sleep, and stress all the time. They are there, and as I said, multidisciplinary. Now, what actually works in obesity clinic? Insights from practice point of view. Let's see. Now, example in 20 minutes, visit template. What we will do for medical nutrition therapy and behavior integration. The purpose, why they are here. Improve adherence, reduce relapse, protect lean mass, translate plans into real life. So what we do, the first 3 minutes, wins and barriers, objectives. We build rapport and motivation. We reinforce the self-efficiency. We identify the real barrier. We don't assume. So no assumptions. Then we have a key questions. What went better than expected since our last visit? What small win you are proud of? What we have similar questions for you in the clinic to show the wins and barriers. What got these are the barriers. What got in the way? So what is the hardest moment this week? Was it hunger, stress, fatigue, social event? You were invited to weddings, birthdays, and you couldn't eat. All of that, medication effects, nausea, satiety, early satiety, constipation. So we look into the wins and we look into the barriers. After that, we have a clinical listing checkout. Skip meals to rebound hunger, emotional versus psychological hunger, sleep diversion versus work stress, travel, dining out, family pressure, medication effects, nausea, and I tick. What is there? I'm telling you what happens in the obesity clinic in real life. That was on 3 minutes only. The second 7 minutes, we go for nutrition prescription, simple and specific. And the golden rule, don't change everything. Let them live their life in actual, because they have to make it as a lifelong thing. Prescribe 1 to 2 high impact changes only at a time. And that's a golden rule. A golden rule. Step 1, choose 1 or 2 to focus target. Example, protein anchor, add a clear protein source at breakfast. Planned snack, 1 planned snack, protein snack to prevent grazing. Structure 3 eating occasions before 6 p.m. Hydration, 1 glass of water before each main meal. And this behavior actually linked nutrition prescription, not macro lectures. Step 2, agree on default choices. Decision, fatigue, protection. So I will not feel boring or I feel tired of following. Explain to the patient, when life gets busy, you don't decide your defaults. Default meal means in the main meal, lean protein, controlled carb, and vegetables. Default meal 2, light meal, protein-based, easy to prepare, low mental effort. Default snack, protein plus fiber or protein alone if appetite is very low. Default, reduce impulsive eating and improve consistency. The other 7 minutes, I said 20 minutes, 3 and 7, 10, and this is 7, so 3 left. The 7 minutes more behavioral skills of 1 week, choose 1 rule, teach 1 skill only, practice it, link it to real situation for your patient's life. And that's one example. Ask when things went off plan, which was presented. Then match the response. Hungry, plan snack. Angry, walk, breathing, pause. Lonely, make a call. I will, if I'm lonely, I'll call Mireille. Hi Mireille, how are you? I miss you, la la la. And then I spend time, I feel no more lonely. Message a friend, talk to somebody. Tired, sleep routine, earlier dinner, like that. So the whole trigger plan, hungry, H for hungry, A for angry, L for lonely, and T for tired. Halt, trigger, plan. And we go in that goal, we separate emotional needs from food decision. 2, restaurant travel script. When I want to go for a restaurant, so I create 2 to 3 pre-decided rules. Protein first, so half portion or share. Vegetables before start. No arriving extremely hungry, so I take a fruit maybe before I come. Script remove pressure from real life situation. Option 3, stress eating replacement, 2 minutes rule, where we in the instructions, we pause for 2 minutes before eating when stressed. Replace action, water or tea. Like Japanese, they like to have tea before food. So we can do that. 4 to 6 minutes breathing, short walk, music, and if still hungry, eat mindfully without a guilt. Option 4, if then plan implementation intentions. If I miss lunch, then I can take my protein snack. If I intend a gathering, then I can start with protein, and this preloading decisions before stress occurs. The last 3 minutes, which is the metric and metrics and next step, we choose 1 to 2 metrics only, avoid or overload. And these options, waist circumference, step count, protein serving per day, hunger, and we score the hunger from 0 to 10, and we track that, what support this target of care and not everything. So we follow up the plan, 0 to 12 week, every 1 to 2 weeks, month 4 to 12, every 3 to 4 weeks, and the maintenance 6 to 8 weeks. And we say this is a skill building for a long-term success, not a short diet. Summary for clinicians, 3 minutes, win and barriers, 7 minutes, 1 to 2 nutrition changes and defaults, 7 minutes on 1 behavioral skill, and 3 minutes, 1 metric plus next appointments. So why this works? Because we recognize the cognitive overload, we align the nutrition with the real behavior of our patients, we support the patients on or off obesity medication, treat obesity as a chronic condition, not as a willpower issue. So in conclusion, obesity is a complex disease and global health concern that require innovative strategies to achieve the weight reduction and maintenance. The complexity and the multi-phased nature of obesity, including a considerable psychological impact of the disease, we suggest the need of multidisciplinary approach. The treatment paradigm for obesity continuity to found it on lifestyle intervention that support nutrition, physical activities, and the reduction of weight management, which is achieved by so many procedures, medical or bariatric. More recently, a new generation of obesity medications are there, even now they try. As patients experience weight reduction during treatment, nutrition plays a very integral role in supporting health while reducing the risk of excessive muscle mass for function loss. Beyond the provision, adequate dietary protein should be there, and the effect also I can suggest the HMBs that show a potential use with risk of muscle loss, and the effect of them actually in some of my patients, those receive oral medical obesity medications, and they reduce fast. I use those supplement with HMBs to support them. We look into the gut microbiome where specific metabolic phenotypes happens, and the current evidence shows that the future role for precision nutrition strategies that considered aspects for patients' experience of obesity beyond one size fits all approach to intervention. These are the evidence based of my references, and I invite you to attend the MAPEN, which is in 17 and 18 of April 2026. You can scan, if you are interested, the QR code to attend. We welcome you to attend our conference, and Dr. Khalid, of course, can share if any one of you, and this is from Mireille. I took it from my Mireille. She asked me to put it, and I'm putting it. I'm not that perfect like her, but this is my Hotmail if anybody would like to ask, my Instagram and my WhatsApp. If you would like to ask any questions, you are most welcome to answer. Thank you very much, and have a good day.
Thank you so much, Dr. Wafa, for this beautiful presentation. I fully agree with you, and I echo, your voice when you've said that obesity is a chronic condition. It's not a personal choice. It's not a lack of power. And, the management is very complicated and puzzled. And that's why, we need all the practitioners, the dietitian, the psychologist, the doctor on board to support, the patient's care. I believe we will leave the questions till the end, but if anybody has any questions, please drop it in the chat box, and we will go for these questions by the end of the session. Now, I will leave it for Dr. Mireille to present our second speaker for tonight.
I would like to comment that Wafa, you did such a good job about presenting the topic from all aspects. And I think we were very lucky, and attendees were lucky to listen to such a talk.
Thank you.
Thank you for being with us. With no further ado, I would like to introduce Dr. Jeremy. Dr. Jeremy Alford is a psychologist with over 20 years of experience in mental health, having practiced across the Middle East, Southeast Asia, and the UK, grounded in clinical psychology. He integrates evidence-based approaches to support individuals with eating disorders and related challenges. Dr. Alford is head of division eating disorders at the Lebanese Psychology Association and founder and president of the Middle East Eating Disorders Association. He's also a senior lecturer at the National Center of Eating Disorders in the UK, where he provides accredited continuing education to healthcare professionals. He's deeply committed to strengthening clinical capacity in the MENA region through professional training, supervision, with the goal of improving care for individuals and families affected by eating disorders and obesity. Thank you so much, Dr. Jeremy, for being with us. It's an honor and pleasure to have you. Please, the floor is yours.
Thank you very much, Mireille, for the introduction, and thank you for having me today. It was a really interesting talk that Wafa gave, and hopefully what I will be talking about goes a little bit more in detail, a little bit more, but I'll just be touching kind of an overview, but definitely in the same line with what was just previously discussed. So let me just share my screen now, and there we go. So okay. Okay, so the big question that we have to ask ourselves first and foremost is why behavior change fails for many. And it's not because people lack motivation, but because behavior change is approached much too narrowly. And so this figure that we see here, it illustrates a typical trajectory of weight change following conventional intervention. So we see an initial weight loss followed by a bit of a plateau, and then we have progressive regain. And this pattern has been quite consistent and demonstrated consistently through long-term trials and meta-analyses. And this tells us something really important, that any form of behavioral prescription on its own doesn't translate to sustained change, because both biological and psychological systems, they push back. And in addition to this, when you overlay this pattern with untreated, unacknowledged eating disorders or binge eating disorder, which is very common in this work, 50% of our patients with obesity actually have a binge eating disorder that hasn't been addressed or worked on. So if we overlay all this and we don't treat the emotional dysregulation or the restriction and binge cycles that are often present, the pathway to regain becomes even more predictable. So it's even more likely that it's going to happen. So that's why it fails most of the time. And unfortunately so. So identification and treatment of these patterns is not an option. It's a foundation that's necessary if we want to improve our care to our patients. So obesity isn't like a single variable problem. We don't reduce it to one issue. It's not, we can't reduce it to willpower or calories or medication. And most interventions target immediate, short-term weight loss, which is often accompanied with weight stigma. We need to talk about that. We bring stigma into the rooms as well. Stigma that is very often also internalized by the person and carried by the person without understanding this, and without our understanding as health professionals of the intricate, detailed layers involved for long-term sustainable change. Without this deeper understanding, then whatever we do is bound to fail. And that leads to further worsening of the condition, because it means that a person's sense of self-worth will be lowered. Their sense of self-efficacy will be lowered. What is self-efficacy? It means it's that sense that we have that I can do this. When I don't have this sense that I can do this inside me, then that thwarts motivation. It thwarts any potential of change. And so the common failure points, if we are to kind of really look at this a little bit more closely, it's typically over-reliance on single entry point. So it's diet, exercise, or nowadays, the GLP-1 medication. Or if we take this further, bariatric surgery. That's the panacea. That's the mindset. And so as long that is the case, then we enter into that state of failure. Another common point here is if we ignore and neglect the emotional regulation, if we don't bring into consideration the importance of a person's thinking styles, what they're bringing into the room, their stories, their beliefs, their identity, the environment, then it's bound to fail as well. And that will lead to rapid disengagement, meaning motivation will drop. So if we really want to think about doing something better, and we want to think in terms of sustainability, offering care that's sustainable, not just quick fix, right? Then we are going to have to rethink our approach. And rethinking that approach means that it'll be uncomfortable. It will be uncomfortable because we're going to have to go a bit slower. And when we've been fed a bunch of information for so long, and a bunch of techniques and approaches that may have seemed as if it worked for a few, then we're up against a big, I would say maybe tsunami, right, of a mismatch of messages that's very hard to break down, you know? So, of course, we know that weight loss can be done very quickly. Yes, we can. Look, this figure here demonstrates it. Yes, we can achieve it quick. But the problem is, it doesn't stay long like this without addressing the underlying issues that are key to doing that. Coupled with these tsunami of messages at even a public health level, and that's probably one of the biggest barriers that we have, because I still think this is still going on today, where this idea of eat less and move more. So I don't know what you think about this, but this is a major problem. It's inaccurate. It's an inaccurate model of obesity and how the reality of how it works. Yeah. So we need to acknowledge the complexity of obesity. It is complex system. It's a regulated biological state that doesn't bend predictably to just platitudes, if not supported by a real good, thorough systemic understanding. So if we think of obesity, it's best understood as a multi-system condition. Perhaps what we can do here is take a look at the biopsychosocial model. We understand that there are factors that are at play that absolutely need to be considered. The interaction between biology, metabolism, a person's individuality, a person's story, as I said before, their background, their family history, the roles that they play, their capacity to regulate emotions, their thoughts, belief systems, the culture where they're in. If we focus only on one domain, it increases the risk of relapse, therefore further worsening of their sense of self. So when obesity is treated as a kind of a system, we chase weight. When treated as a system, we support change. We move away from a position of blame and powerlessness to a position of collaboration and motivation. So this figure here really demonstrates the layers. It's the following what I call here the balloon model. The balloon model of sustainable change. That's the work. That's the work. And we need to be looking at it as multiple entry points, multiple points. And in no order of priority, we must meet the person where they are. Every person is different. We need to meet them where they are. And that comes with the skill of the guide, the therapist, the coach, the practitioner, to be able to really learn how to connect and develop a proper therapeutic alliance with a client, to maximize engagement, to build motivation so we can move towards something that's sustainable. So we're going to be looking at all of these different areas: lifestyle, a person's routine, activities, a relationship. We will be examining a person's physiology, of course, the effects of what's happening in their body, their cortisol, their sleep. We need to be looking at their nutrition, the different type of foods, how much processed foods, how much ultra-processed food is involved, and so on. We need to be identifying and exploring the meaning of food. Do you do that? Do you explore with your patients the meaning of food with them? We need to do that because we could spend hours with someone exploring just that. Yeah. Attitudes. We need to look at the detail of a person's thinking styles, what it means about them. What is their motivation to change? Yes, they desperately want weight loss. We need to examine that a bit more closely, because we know fundamentally that any kind of weight loss thinking leads to disinhibition. Yeah. So what does that mean, disinhibition? It means that the person is going to eat for non-appetite reasons. Any kind of weight loss thinking is bound to put unnecessary pressure for them. So we have work to do. We cannot treat like nutrition as separate from emotions, or ignore a person's thinking or belief system and yet prescribe a behavior change, or expect medication to override a person's habits. Yeah. If we pull only one lever, the system compensates somewhere else. So we use this model, the balloon model, to better help the person understand what's going on for them, so that they can have a better understanding of what's going on for them. And yes, we will have to address stigma in a very, very specific way. Because the moment that a professional or anybody agrees that a person loses weight, we run the risk of having brought stigma into the room. So it's a very sensitive thing that we need to understand what that means. So how can we fundamentally help someone without bringing stigma or reinforcing stigma? So we need to really listen to the person's real motivation to change. Maybe a real motivation to change is that they want to be able to live life with more flexibility. Maybe they want to live with less pain because it's painful. Their knees are hurting them. They can't walk properly. Yeah. They're scared that they may not live long enough to be able to spend time with their grandkids. Right? So this is where we need to be going, and not just weight loss, right? And what that carries. What's the motivation? See, and if a person has an ideal weight that they're focused on, we will have to explore that together. We will have to explore the person's personal physiology, because everybody has a different body. So work around that. Work around a person's lifestyle adjustments. What are the barriers, the obstacles, how to develop psychological strengthening, mental strengthening, emotional regulation, a better understanding of the obesogenic environment that we're living in, how to become more assertive, how to cope with comments, you know, a lot of skills we teach along the way, early childhood experiences, how that is impacting them today. Do they have a weight conflict? We call it a weight conflict. Maybe how come they're saying they want to change, but for some reason they keep doing the opposite of what they really want? Is there a part of them that doesn't want to change? Who are they changing for? These are underlying issues. We need to address them. See, once the person has a better understanding of what's going on, then they have better awareness. And when they have better awareness and the right skills, because many do not have the right skills. So with the right skills, this will empower them. So we are focusing on health behavior in our approach. We're coming from a health psychology approach to behavior change. Now, I don't know if you're familiar with the National Weight Control Registry, but in 1994, the NWCR was established, which is a research program that tracks individuals who have successfully maintained significant weight loss. And it aims to understand the behaviors and the psychological traits that promote sustained weight management and prevent relapse. And something amazing was discovered as a result of all of this, is that there are specific predictors that we know can help a person to flourish in their life. And health improves as a result by default. We're moving away from weight loss thinking. We know that weight-focused approaches increase pressure, stress, shame. Weight loss thinking is an all or nothing thinking. We think in extremes. And rates of dropout are high when the person doesn't see the result that they should be seeing by now, right? If that makes sense. And instead, we need to be focusing more on a person's behavior, what will help to increase their sense of autonomy, strengthen self-efficacy, develop psychological flexibility. All this will lead to sustainability. Yes, we know that GLP-1s now can support weight loss, but we know very well that they don't teach behavior change. We know that they can suppress appetite. Yes, we can see quick reduction in weight. It can be a solution, but on its own, that can be catastrophic for many on its own, especially for those who decide they want to stop it. And within the same year, they will see up to 70% back within the first year of their initial weight will just come back so quickly. So we need to be informed. That's the key thing. We need to move towards informed care. Yeah. So what we know clearly is that these GLP-1s don't work on emotional regulation. They don't address a person's thinking. They don't address a person's body image disturbance. It doesn't tackle the relationship issues that they have. So we run the risk of having all kinds of problems there. So medication can open a window, but behavior change and tackling all the layers is what determines what happens and how sustainable it becomes. Yes, bariatric surgery is one of the most effective interventions we have in terms of biological impact. We see significant weight loss, often 20, 40% of total body weight. That alone tells us something important. Obesity is not about willpower. But we also know that surgery does not bypass learning. It doesn't bypass emotion. It doesn't bypass identity. It doesn't bypass environment. It doesn't bypass all these little these details inside of us in the psychology of who we are. So we need to be addressing all these different things. Yes, surgery changes a person's anatomy. It doesn't automatically change a person's habits and coping strategies. So we need to do better pre-surgery preparation, followed by post-surgery preparation. I've met numerous people who went under surgery. The change was so dramatic. They ended up having another problem. They hadn't realized the psychological impact it would have on their identity. A person's weight change changes their personality. Sometimes a person is not ready for that, and they don't know that they're not ready for that until it happens to them. And then they have trauma. So what about all these messages we're getting all over the place now, especially with social media? People have become now pseudo specialists. I know the information because I saw it on TikTok. I know more than you do now because I saw it on Instagram or whatsoever, right? It's dangerous. Unfortunately, it is what it is. Powerful. It's got a great positive potential, but it's also, there's so much filtration that we need to do. And that's what we need to be also tackling with them in our work. How to be more informed, how to help them set more realistic expectations, right? And people's different ideas about what they have about health and weight loss, right? Thinking that weight loss means health. A lot of people who are, in different shape of bodies and are much unhealthy than a person's, in another body. So it's the ideas we had and what trends well online often performs poorly in long-term outcomes. We need to bear these in mind also. So what actually sustains behavior change? We know, coming from a health psychology perspective, that's what's very exciting, is that we see a lot of possibilities of addressing a lot of these issues. To assess a person's readiness to change, to assess a person's willingness to change, to assess a person's ability to change. I might be ready, but not be able. I might be not ready, but able. So we need to really address these things. We need to be addressing something we call the intention-action gap. Because I might tell you I want to change. I might tell you I believe I want to change so much, but my actions don't back it up. So we need to be exploring that. The wider the gap is, the less they're going to change. That is an indication that they're not as ready as they think they are. So we need to help them bring the gap, to close the gap, make it closer, more closed, if you like. So we're going to be using, like I said, psychological strengthening, to use a lot of motivational interviewing techniques, how to build a life in which There's not just one egg in their basket, but many eggs in their basket of life, so that they can live the life that is one of flourishing, right? We know that from the NWCR, people who are doing things because it's fun, they're doing tiny things that they like, end up having better results than those who are focusing on, I need to achieve this weight loss now. So we need the input of a multidisciplinary team. The future I see of obesity care isn't better motivation or stronger medication. It's a better system of care, where we are health professionals working in the same way, with the same approach, that we all speak a similar language. That will be most helpful, and not have different health professionals saying different messages or simply agreeing to do a surgery or to give a medication because that patient just told them and they feel compelled that they should do it. And yet what happens is that they brought stigma into the room in that moment by doing so, and worsen the person's care long term. We're sending the wrong messages. So if we want sustainable outcomes, we must stop asking our patients, clients to change in an isolation, and to start really looking at obesity for what it is, as a complex system that it is. The evidence tells us something that's uncomfortable. Sustainable change happens when weight stops being the center of treatment and life returns to the center instead. Life, flourishing. What is the meaning of flourishing? Changes. So I also teach, I also give trainings, CPD trainings. Would be happy to share this with you. And there you go. Thank you.
Dr. Jeremy, I think I know why people come to you for psychological help. Your voice and the tone of voice was completely different than hyper anxious healthcare professionals, dietitians, and physicians that we usually are, and we listen to each other. Your voice was so refreshing. Look at Wafa and Muna, they're
I
confirming. And I know
swear I wanted to say the same sentence. I
I want
already
to
have
listen to him
like
all day.
hypnosis. What you call hypnosis?
Yeah,
Of the
Hypnotic.
voice, خلاص. I am like, okay, I
my
can
nerves are
understand.
calmer. And Wafa
Yes.
knows I've been up since 5:30 today and back to back. And I needed this voice. I think I'm going to record your voice from time to time. Just listen for
Yeah,
one
just
minute, just to
listen.
calm down.
See? And you see me, I was like, "Ta, ta, 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 ta," and he comes with a
Yes,
calm.
yes,
Oh
yes.
my God, they are
Your
relaxed
patients are
now.
lucky to have you.
Yes.
Thank you.
I think you touched upon such beautiful things. I love the fact that you said obesity should not be managed in isolation. And then you talked a lot about patience. And I think these are things I wanted to kind of highlight because, we are in a day and age that everything has to be fast. And if it's not yesterday, then it's not done. Everything has to be done yesterday, not even today. So I think we're kind of in a and this obesity is becoming also part of that whole deal, right? Everybody's anxious, running fast, trying to unrealistic fast solutions, and we're just burning and crushing, right? When we're doing that. Yeah.
Absolutely.
Yeah.
Absolutely. And we are doing people a disfavor
Oh,
in
yeah.
that sense. And yeah, especially with all the social media and the information that we have all around us, it doesn't help.
And as you said, and I think Muna also said earlier, everybody now is a specialist about everything.
Yeah. Yes.
So I want to go to the questions. I think I'll start with the ones that started with Wafa, if you don't mind, because they were earlier and they've been patiently waiting. So Wafa, one of the questions was, how do you ensure behavior change persists beyond the initial clinical window? As per our strategy, or maybe this is for, I think, maybe
No,
Jeremy.
that's for,
And
yeah. I answered
yeah,
a couple of questions
yeah.
while Dr.
Okay,
Jeremy was.
okay, excellent. Okay, so it's more on habit building. So what is your strategy on habit building, especially when biological adaptation promotes weight regain? How do you ensure behavioral change and persisting sustainability?
Is this question for me or for Wafa?
For
Oh, you for
Jeremy,
you.
for yourself, because
Ah,
it's
it's for
more on
me.
habit
Right.
building.
Well,
Yes, yes,
well, it's
yes.
a great question. I think, a first thorough assessment is really essential. And I do this in a very specific way, where I will take a person's permission to notate part of their story in the form of symbols and drawing. And that's one of the things I teach on the course that I give, on how to actually do an assessment instead of doing it in the typical standard way, which is written, and you're taking your notes this way, for example, is to do it in a way that's engaging with the client, so that suddenly what's going to happen at the end is that they will see a map of their life that will be so surprising to them. It will highlight all the different patterns that's going on for them in a very short time. And based on that, you will then be able to give the client back what you think is keeping them stuck and what the roadmap to change will look like. So it's a soft entry point of really laying down, I call it like really starting very well. You start well by laying the ground, all the different elements without overwhelming them, obviously, but to show them a little bit bits of pieces. Once the person has a bit more information about these things, you're already starting in the right direction. And that's where you begin to teach them different skills that will become then habits,
Mm-hmm,
right? And monitoring is important. And I know people
mm-hmm.
don't like to do that. I think
Yeah.
this is the most difficult thing in the world, is to monitor, right? Or to keep
But
track.
but I think if monitoring is followed with feedback, it
Yeah.
could actually be exciting.
Well,
So
exactly.
yes,
Absolutely.
yes,
100%.
yes,
So it's a
yeah.
reframe about it. It's
Mm-hmm,
reframing about it, because it becomes every time we see each other, we are going to discuss it together. Yeah.
mm-hmm,
And
mm-hmm.
then we, instead of using it as a tool for negative reinforcement, or they don't like what they're reading, it
Yeah.
is becomes used as a tool for self-discovery, exploration, and notating, giving yourself kind of like positive reinforcement stars, let's say, every single time you begin to apply one of the techniques that you've learned in session. So you learn how to positively reinforce yourself.
I love the stars that you're saying, because it's like it touches on gamification. And it
Mm,
seems most of the apps right now become addictive when they have this gamification and positive reinforcement. So I
mm,
think maybe we as healthcare professionals can learn a little bit, and do
mm.
some of that star gamification and scoring. That it's not a
Yeah.
health metric, but it is something that is bite-sized, understandable by the patient. It's not,
Mm.
some blood test that they don't, it's a gamificate. It's, I think, yeah, I like what you're saying. I have one more question. Is resource constraint in resource constrained settings, what scalable models exist for embedding multidisciplinary obesity care into primary health system? It's usually one point of contact managing everything usually. Yeah.
Well, talk about anyway, even if it is in very low constraint, they will have the physician, which I mean, he's most of the time handling. The nurse is there. He can call for a psychologist, I think. And the dietitian is the problem. Most of the places they don't have in clinics dietitians. So I think the doctor, which I see in many clinics, that he is doing the role of the dietitian. So I think what Muna have said earlier about the mobile clinics, they can refer them to the dietitians, whom can give, or he can make, which once you suggested that role model, that they can link with a dietitian with that clinic, to just refer those patients, so they will can be a multidisciplinary team. I don't know what about Jeremy, what is his point of view of that?
Yes, it is. It's well, as you said, I would just second that. The multidisciplinary team having one point of one spokesperson, perhaps, one who will probably lead that, which I would say actually the person with who you have the closest relation with. So
Yeah.
it would be you know, uh, the one coordinating uh, kind of that. So I would say like the psychologist,
Mm-hmm.
the
Mm-hmm. And somebody
yeah,
who has more time and patience than an acute care physician,
yeah.
Yes.
Yeah.
you know?
Again, I go back to start well, and you
Yeah.
must have a specialist therapist, psychologist to take the lead in this
Mm-hmm.
from
Yeah.
the
I
beginning.
mean,
When you have a patient that or client that comes to the hospital or to the facility, this should become your procedure.
mm-hmm. Mm-hmm.
It
Mm-hmm.
starts there, really.
Yeah. Yeah. What do you think, Mona?
Yes, I fully agree. And also, beyond the clinical settings, like, yes, in the hospital or in the clinical, we have a multidisciplinary team. But I think also we need to utilize more tools, like, for example, the digital wearables that can also could be considered as part of, like the monitoring techniques that can also support the patient. And also, I do believe that there is also a role of the community support. So when there is also like an awareness, when there is like a workshop coming from the community, when there is a support group, also like when there is testimonials coming from the people suffering from the same concept, also this can put all of these pieces of the puzzle together when it comes to obesity. And also, I would like, to thank you so much, Dr. Jeremy. You've mentioned something very important. Let's put the weight on the sides. So when
Yes.
we remove this focus from the weight, because patient, they're just looking at this number. But
Mm.
maybe if we focus more on the health benefit, if we focus more on flourishing, enjoying life, I believe a lot of, this system that is kind of like blocked will start to to see some of the light. And I believe when it comes to obesity, it's never a destination that we're looking for. It's always a direction that we as providers, we're all looking to put this patient on maybe the right direction. And deviations are acceptable. We
Yeah.
want patients to have those deviation, to enjoy. We're not robot, so we want to allow this thinking, and we want to let patients understand that we're not in to have this perfectionist target. So this is something really important. Yes.
Mm.
Yeah. Yeah. But it needs a system change, no? Because
Yeah. Agree.
nobody's like that. I think we need to find a way to show how cost effective and maybe how money making all these processes that we're saying are, so that actually people and investors, invest in these processes, because right
Mm.
now nobody's investing in our processes.
Hmm.
True.
That
So yeah, I
agree.
think that's
Sadly,
the thing, right?
it's
I,
welcome,
Yeah.
I
actually.
I'll
Yeah.
take
Yeah.
one more question because of time restrictions. Question from the nutrition perspective. With the holy month of Ramadan coming in under 2 weeks, how important is Ramadan nutrition plan, especially for those on obesity medications? And what is classical Ramadan nutrition plan in this case?
Well,
Uh,
actually, today in the clinic, I had the patients who is on or in those oral medication. First of all, with the communication with the internal medicine, the one who prescribed, we agreed on doing something, decrease a little bit the dose,
mhm,
and make sure that they well hydrated, and they start with protein and with protein. Make sure that the suhoor, that main meal that have the highest amount of protein, that makes them not to have any problems for the Holy Ramadan. So again, it's a tailored, individualized precision nutrition among the patient's medication needs and ability of what they can do or what they cannot do. But hydration and protein is the most thing that me and doctor, let's say the internal medicine, which I have in the hospital today, we decided that together we designed that and tailor it accordingly. And actually today I had that they don't want to stop the medication. So he
mm,
did the doctor decrease from the highest dose to one level low, and he made sure that I distribute the proteins up to 30 to 35% with the iftar and with the suhoor, you know. And there was a snack in the middle that it also have a protein if he missed the protein in his iftar thing. So again, it's tailored according to the patient's needs. Yeah.
Yet one more challenge that has to
Yeah.
be addressed, right?
Yeah. True.
Okay, I think because of a matter of time, I think we've
I
answered
answered most of the questions
yes.
anyway in written. Yeah, I answered
Yes.
most.
And I see there's a little bit of repetition. And I see that somebody has asked how to make insurances actually pay for dietitian and psychologist rather than medication. And this is exactly what we were talking
This is
about.
what you have just said,
It's major
Mireille.
problems.
Yes. And I saw the
Yeah,
question. I'm
true.
like, okay, yes.
Yeah.
Well, yeah, and some of the guidelines do say that integrating more health technologies within, because there are not enough dietitians and psychologists anyhow, even if they are given the chance to see patients, to actually see each patient with all their needs. Yes, because of stigma and taboo, not everyone who has so many questions will come to you, and then so like I'm very much now into clinician trained AIs that can help patients, but clinician trained AIs, not AIs that are, I don't know.
Correct.
There was
randomly
a questions actually, Mireille, about the AI, and I answered them. About the AI, it can help clinician treat humans, more precisely. But AI doesn't treat obesity. It
Doesn't
helps
treat the
the
clinician.
treatment,
Yes.
but doesn't
Yes.
treat. So that was one of the questions actually that I have answered.
So this hot topic with all these questions, with all of these
We had to
comments,
give a lecture about it.
very clear that Obesity Fellowship will shed a lot of light to everyone who's working in this domain. Make sure you register. We've got an early bird, discounted prices, and all the speakers that were today, and they will be in other sessions. You're getting a glimpse of them, but you will have a more thorough version of their thoughts and learnings and teachings in the fellowship. So don't forget to register and see you in the fellowship. Thank you everyone for being here.
Thank you, Dr. Jeremy. Nice meeting you.
Dr. Jeremy, Dr. Wafa.
Lovely meeting you
fantastic.
too. Yeah.
Thank you, Dr. Khalid.
Meeting you.
Yeah,
Hope to see
thank
you
you,
again.
Wafa. Thank you, Dr. Jeremy. Actually,
Thank
I
you.
learned a lot today in the webinar, and I hope to be with us in the future webinars, inshallah. Thank you very much.
Thank you,
Have a
Mona, for
lovely
moderating.
evening.
Thank you.
Bye.
Thank you
too.
so much
You
for
too.
all of you.
Thank
Bye-bye.
you.
Bye-bye, Mama.
Bye-bye.
Bye. Good
Bye,
night.
Mireille.
Bye-bye, everyone.
Take care.
Bye-bye.